Here is Lucy with an opening karakia for us.
Ko te wani te kune te pete kore te po. Ki ngā tangata mari ngā rangi raua ko papa. Ko te nei te timatanga o te ao. Ko te nei te timatanga o te ao.
Right, it's still singing and didn't come from me. So today we're going to talk about osteoarthritis, particularly from a primary care perspective. Next year you will have osteoarthritis from an orthopaedic perspective in musculoskeletal care. And what we're going to talk about is in 3 sections: presentation and diagnosis, funding, as in who pays for care, and then management approaches to that. We will have a mixture, particularly we'll have a group exercise for funding, and then we will have some pair exercises in the management so that you get to do some stuff as well. For just setting the scene for what we are talking about, best we have a understanding of, well, one, how I understand osteoarthritis, although this was developed with Hamish Osborne, who you might remember from ELM. He was a sports physician who teaches into that program. So osteoarthritis is a dynamic process, and we will come back to process as being an important element, where mechanical stresses and catabolic processes, so it's not all about the mechanics, overwhelm the joint's capacity for repair. Characterised by gradual change of articular cartilage thickness with effects on underlying bone, menisci, synovium, and secondary compromise of joint function, including muscle activity. And the involvement of all of those tissues and the joint as an organ is something we will talk about. And finally, it results in a clinical syndrome of pain, functional limitation, and impaired quality of life. And so we will also focus on clinical aspects of this as opposed to it being a radiological condition. Right, so first of all, where do people commonly get osteoarthritis? Knees, yes, and knees make up, actually take a guess, what proportion of the burden of osteoarthritis in our community comes from the knees?
70%.
Higher. 80%. Why do knees account for so much of the osteoarthritis burden? Yes, but do they take any more force than your ankles do?
Because they suck. It's a bad joint.
Is it a bad joint?
When you think about how it's like made for its purpose, it's not very well designed.
I don't know. I mean, I can stand with it straight and it's nice and stable, but I can squat all the way down to the ground. I can jump. I mean, that's pretty cool, isn't it? And sideways.
Is that why? Because it's so mobile. Is the ability to injure it more?
So injury is the thing that is the key contributor to that. So it's possibly not so much the design, but design is a word that we've got to be careful about using in terms of the way the body is made. Hey, the way in which the joint evolved, it didn't involve us playing lots of netball, rugby, things whereby key structures are frequently exposed to challenge and fail. So what's the key structure that fails most catastrophically in the knee when doing those things?
ACL.
The ACL. And often that happens in people who are young. Okay, when that happens to the joint, and then there might be associated meniscal change, subchondral injuries as well, that joint is therefore more likely to develop secondary osteoarthritis, and really early in life. So, people who are in their mid to late 20s may have osteoarthritis, and so they then live with that condition for 60 years, as opposed to hip osteoarthritis, which is primarily primary OA that develops much later in life, and so people have got a much shorter window in which to live with it. And so that's why knees are so much of the burden of OA, and why they'll be a focus of what we talk about a lot today, because most of what you know about knees can be applied to other things, but they're something on which we've got most evidence. Okay, so knees are a big part. Where else do people commonly get OA? Hips.
Shoulder.
Which part?
Joint.
Which joint?
AC joint.
Yes, so the AC joint is a much more common site of primary OA. So people get quite localised point of shoulder pain, and they get a loss of end of range elevation, and that's much more common than a glenohumeral joint osteoarthritis, which is more, a secondary OA after a joint fracture or an infection or something else that has compromised the joint earlier. Yeah, where else are we thinking in the back row there? So hands and fingers, what's the most common part of the hand to get OA? Beg your pardon? You're going to have to get your teammates to help you on that one. The MCP? No, it's not the most common. It can happen, but it's less than the... What's the joint in between one phalanx and the other? The distal interphalangeal joint, yes, but that's less common than... No, I don't think I do. No, probably DIP would be more common than PIP. No. No. Yeah, which part of the thumb? No. Yes. So the carpometacarpal joint is relatively common for OA as well, but doesn't tend to impact people's quality of life to the same extent that if they have significant hip or knee OA does, but can still be a significant limiter on people's ability to work. Yeah, where else do people get OA? Yes, so in the feet. Yeah, so neck and back is an interesting one for us to consider in terms of often radiologists will talk about osteoarthritic changes in neck and back, and people will say, I've got osteoarthritis in my neck and back. However, if we look at osteoarthritis as a clinical syndrome rather than as a radiographic syndrome, many of the signs and symptoms that we would use to make a diagnosis of osteoarthritis are not present in those people who have those changes. And so I guess it's an open question as to how often it is osteoarthritis that is causing these purple symptoms or something else that hasn't been identified. Excellent. So we are going to, or I will draw your attention to this guideline for managing hip and knee OA, that many of the recommendations that I share with you today are within that document. It's one of the best clinical practice guidelines I have come across, and so worth looking at just for how to structure a clinical practice guideline well as relatively good recommendations, although it is from 2018 and they are updating it currently, and there are a couple of recommendations that might change, and I'll highlight those as we go through. So, in terms of presentation and diagnosis, I would like you to understand what the typical symptoms of an examination findings of osteoarthritis are and how to relate those to recognised diagnostic criteria, and when you may use diagnostic imaging and why. So, what are the signs and symptoms that people with osteoarthritis will come into your clinic room with?
Pain.
Yeah, and pain when?
I was thinking more towards the end of the day.
What would be the common feature of when someone hurts? When they're using their joint. So joint related or movement related, activity related pain. Now the morning can be part of the feature. What would we be looking for in the morning? Yes, and how long should that last for? Yeah, not more than half an hour is what many of, so it's short-lived morning stiffness, and that if it's a long morning stiffness, you might be thinking about inflammatory arthritis rather than a osteoarthritis. So we've got usage-related pain, we've got short-lived morning stiffness. What else?
It's to be like asymmetric or like only a few joints affected.
Yes, so yeah, it shouldn't be systemic. But people might have it in both hips, both knees, or both hands type thing.
Would age be a factor? Like let's say if a teenager, like 16-year-old presenter, won't be arthritis.
could be osteoarthritis, particularly if after like juvenile rheumatoid arthritis, that can result in joint change, so that somebody has osteoarthritis as a very young person. So it is more prevalent in older people, but it is not uncommon in young people. And we've got to keep that in mind. So you wouldn't want to not consider it as a diagnosis because of the person's age, but we'll talk about that in another slide. Yeah, what other signs and symptoms?
Reduced range of movement.
Yes, so reduced range of motion.
It's chronic. It's not like a one-off.
So yeah, it should have been persisting for a while. It shouldn't be related to an acute change in the joint, although it has to start hurting on one day. Yeah, what else?
The type of pain, like how are they describing it?
I suspect often people might have aches, but at the same point, there's often sharp pain associated with. So I'm not sure the nature of the pain I would use as key diagnosis.
They could have those Herbert-Dean nodes on the...
Yeah, so they might have what would be called bony thickening or osteophytes, so you can feel that thickening around the joint. Yeah.
Can you feel like inflammation, like hotness or?
Well, you shouldn't, and that osteoarthritis shouldn't be an active inflammatory process. You can find some inflammatory cells if you go looking for them, but it shouldn't be hot enough that you should feel. But what might come with a low-grade inflammatory process that you will see?
Swelling.
Yeah, so you might see an effusion with that as well. Yeah? What else are you going to see when you examine them?
Might affect their gait.
Yes, so they might have altered gait, altered comfort in loading.
Do you see like locking?
Well, they might report locking. If it comes in and it's actually acutely locked, you're going to have to broaden your scope of things you're thinking about as to what might be causing this problem.
Like crunching?
Yeah, so
Like,
crepitus is a commonly reported thing and observed thing. Mm-hmm.
Do they have like, I don't really know if there's a word for it, but like signs of using the other limb more often or something?
So they might have a loss of muscle bulk from disuse. They also might have changes in the alignment. So you might see a varus or a valgus deformity. And often people talk about, particularly with their knees, giving way, which will also be associated with change in muscle function. So this is from the University of Melbourne, where they just did a nice infographic where I think we came through all of those ligamentous instability. So that might come with, if you've got a big valgus, then most of the time your LCL is going to be offload. And so therefore you've got a massive amount of range you can get to put it back on load, and so that will feel quite unstable. Okay, so one of the things that we've found, we did some research where we looked at the notes of everyone in Tour Compass Health, looking for signs of osteoarthritis and for how GPs diagnosed it. And what we found was there was no consistent way in which GPs reported OA, and they didn't seem to be using any agreed clinical criteria. And the problem with that means that often osteoarthritis is going unidentified. And if it's unidentified, that means the person doesn't have access to information or care choices or anything else that might improve their quality of life, even though the condition is affecting them. There are actually some really good diagnostic guidelines that you could be using and that I would encourage you to use. There are three here. One is the UK National Institutes for Healthcare Excellence. Second one is the European League Against Rheumatism, and the third is the American College of Rheumatologists. Now, I've shown all three because the nice ones are the best ones for us to use in primary care, and they're really simple. You need to be 45 or over, have usage-related joint pain, and your morning stiffness doesn't last longer than half an hour. So it's really inclusive, and it's been found to be the most sensitive and specific for capturing OA in primary care. But you've got to be 45 to hit the criteria, and many people in our community are under 45 and they have OA. So the EULAR one goes down to 40. and you need to additional have a functional limitation as well as those first two. And one of these other things we talked about in terms of crepitus, restricted range of motion, or bony enlargement. But again, you've got to be 40 versus the American College of Rheumatologists, you can be any age, because that's the only thing you have to have is activity-related pain. And then you've got to have 3 of these other signs. And so that gives us the option to diagnose clinically in people under of any age. Yes?
Why does it say 50 above?
So that is one of, if you're looking for the 3 extra criteria, you only need 2 of these ones if you're also over 50, but if you're under 50, you need 3 of the other ones because it's slightly less likely in people under 50, and so we want more evidence to support that. So, though you'll need to meet the inclusion criteria, but also need to make sure there isn't any better explanation for your symptoms. And so, we don't have recent trauma. There's nothing to suggest that it is inflammatory or an acutely changing thing, like a gout or other type of arthritis. And there are a few unicorns that do present as gradual onset knee pain in terms of tumours as well. Okay, now, what is the difference between the foot on the left and the foot on the right?
The one on the left's from an animal.
Which one? Yes. You're quicker than many classes on this. Many classes, they go, oh, look, I think there's something with the growth plates. There's an expanded fat pad there. Is there something funny with the calcaneus? The key thing is, how cool is it that an elephant's foot looks that much like ours? But the other thing, and the reason why I put this up, is if you just look at the bones out of context, you miss the big picture, hey? And you can miss a lot of what's important in terms of understanding the situation. So let's go to one that's actually of a knee. So this is a person who presented to me with unilateral knee pain, and clinically diagnosed as osteoarthritis, had crepitus, limited function. Which of those 2 knees was the one that hurt? Put your hand up if you think it was the right one. All the way up. We'll get the physical activity here where we can. If you think it was the left one, all the way up. Okay, and if you can't tell, all the way up. Okay, so why did you say left?
Just because the way you're phrasing the question makes it sound.
Or why did you say right? Oh, not right, why did you say neither?
I just don't know.
Yeah, well, see, what's interesting with this person is he'd just retired. He was used to being really active, and he was looking forward to doing a heap of tramping and other active stuff in his retirement. But he didn't have health insurance. And he'd been told, he'd read the X-ray report that said that he had osteophytes, significant reduction in joint space, he had subchondral sclerosis, I think they might even have found a cyst somewhere, and he was devastated that his whole expectation for his retirement had changed. However, when I looked at the X-ray report, it was talking about the right knee, but the one that hurt was the left one. And I was the 4th clinician he had seen, and the first one who said, oh, well, you don't need to worry about what's on the X-ray. That's not the one that saw. And that completely changed his outlook, because he certainly has clinical osteoarthritis in his left knee. He met all of those clinical criteria, but you certainly wouldn't think about replacing that joint. So there are other treatment interventions that are a lot more likely to be effective for him, but also could say to him, look, don't worry about joint change. Joint change doesn't have to hurt. And he's not unique in this. So there's good evidence that clinical and radiographic diagnoses of knee osteoarthritis are quite often discordant. So now I have just taken a liberty with this where they've talked about radiographic osteoarthritis, and I have gotten rid of that because I don't think such a thing exists. There are changes you see on an X-ray, but you only get osteoarthritis clinically. And if we can separate those out, then we will be able to interpret X-rays much more meaningfully and also convey that information to people much more accurately. But what they found is that For those who have radiographic knee changes, somewhere between 15 and 76% have knee pain. And with, those with knee pain, 15 to 76% have knee changes, and those with knee changes, 15 to 81% have knee pain. So there are two Venn diagrams that get some overlap, but lots of people on both sides. And so their conclusion is that radiographic knee change is an imprecise guide to the likelihood that knee pain or disability will be present. And so that's why the diagnosis that we want to make of osteoarthritis is a clinical one based upon those clinical signs and symptoms. And we do not need an X-ray in order to help that, because it's likely to confuse us more than it is to strengthen that diagnosis. Yeah? What questions do you have about that? Yes?
So you said like there's like change to the bone of the right, depends on the left. So how do you go about in terms of like treating the patients and sort of like exercises or like?
For the right?
Yeah, for the left.
No.
Sorry.
Oh yeah, for the left, I manage it. We'll talk about management in the last section of the class. So all of the osteoarthritis management strategies are still entirely appropriate for that person. But the key thing, I mean, he came in and said, thank God my right knee is still good. And so, you know, for him, that right knee was his strong one on which he did everything. And so we want to maintain the health of that knee, but we don't need to think about trying to modify what that joint looks like. So, if we're not going to use it to diagnose, when would we investigate a knee with suspected osteoarthritis?
So if they have any signs of like infections or like a symptom.
Yeah, so if we've got a different diagnosis that we need to rule out. Yes, and if you're thinking that you want to refer this person for a joint replacement, because that person previously, people had offered him a joint replacement for his osteoarthritic knee, but there's no way you should have replaced his left knee because there is not severe joint change. And so those are the two key times, is that atypical presentation or uncertain diagnosis or consideration of surgery. And most of the time, plain films are what we want to use to look at that. That gives all of the information you need to plan a joint replacement surgery. And so advanced imaging will only be used if we're really trying to, you know, confirm more or rule out more infrequent diagnoses, such as, you know, osteonecrosis or you know, an insufficiency fracture or infection, something like that. Does that make sense? Any questions about diagnosis? Because we're going to move on after this to talking about the funding. Cool, if any occur to you, we can come back. But let's get on to funding. So, the learning outcome for this is to understand the role of the health system in funding the care of people who have osteoarthritis. So, who funds the care of people who have osteoarthritis in Aotearoa, New Zealand? So, ACC funds a portion, and we'll talk about that a little bit more in the group exercise that you'll do shortly. Who else? A big pardon?
Private healthcare.
So, private healthcare, who pays for private healthcare?
Which person?
Yeah, so people pay for a lot, and that might be through having contributed to health insurance over time, or it might be their direct out-of-pocket expenditure when they need care. Yeah? Who else?
Public health, like the public health system.
Yeah, so Te Whatu Ora also funds OA care. What do they spend their money on?
Either joint replacements.
Yeah, on joint replacements. So nearly all of the Te Whatu Ora money that is spent on osteoarthritis is spent on joint replacements. Now, what proportion of people who have osteoarthritis, and if we think about, you know, joint that's the most commonly replaced, so we'll talk about knees, what proportion of people, or knees and hips, of people with knee or hip osteoarthritis end up with a joint replacement?
5%.
More?
20.
Less.
10.
10 to 15, okay? And then at what stage of their osteoarthritis journey do they receive that? Right at the end, okay? So if we go back to when we were talking about, people might develop osteoarthritis in their 20s, and they might get a joint replacement in their 70s, and so they are living with the burden of this over many decades before the public health system gives them any support. And that's if they're in the 15% for whom they might get a joint replacement. For the other 85%, there is virtually no public health funding for osteoarthritis, and that is a significant impact on our country because it's having impacts on the people's ability to participate in life and work and all those other things, which has costs. And so that's certainly a model we want to think about. What I want you people to think about is to break into, now how many have we got here today? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Okay, so we need 6 groups. We've got 20 of you, so that will be mostly groups of 3 and 2 groups of 4. What I have is a scenario which has some features altered in it. And what I want you to do is in your group to discuss who would pay for Maddie's care, who's the retired landscape gardener this is about, for any care they need right now and any care they should need in the future, particularly if they substantially deteriorate over time. Okay? So I want you to talk about that, and then we're going to talk about that as a group. On the sheet there is an orange highlighted box, and that's the one that you are to look at. So if you could break yourselves into groups of 3 or 2 groups of 4. So for scenario 1, if you could, because everyone's obviously just focused on their own scenarios, so if you can read out what your scenario was and then tell us what your considerations were.
So does everyone have the first?
Well, not everyone's got a sheet, so...
So Matthew Sturm is a 67-year-old retired landscaper who has BMI 23. Pain started following a sudden unexpected hip twist when the greyhound shot off to chase a rabbit while on the lead. Acute pain fails to settle, signs and symptoms consistent with moderate osteoarthritis, and X-ray demonstrates moderate joint changes.
Right, so what did you decide? Who's going to pay for Maddie's care?
In the acute initial period would be ACC, given that was the greyhound running off that injured. Long term,
yeah, long term we thought it would be private, like their own kind of funding, because we're not sure if ACC covers osteoarthritis because it's more of a chronic.
Yeah, like how long following the acute injury they would fund it, and then the X-ray shows moderate joint changes, but I guess if it was to develop to like very end stage, not like very severe, then to fight it water would be involved, and we're going to get a refugee replacement, but that's not like at the moment.
Yeah, okay, so excellent. So this person would qualify for an ACC claim for this acute event because there was an acute accident that resulted in this joint injury, or we've only got the pain as being the presenting sign for that. But you're right that those X-ray changes can't have become from that acute event because they just can't develop that quickly. So therefore ACC has a get out of jail free card for ongoing care because they can say, look, those changes were already there, they're not our fault or not our problem. However, there might be a question for how long that acute care goes for, and that's quite variable in terms of at some points, if somebody asks for something additional from ACC, somebody at ACC is going to review it and say, hang on, we don't think we should pay for this. But other people might be able to dribble on through the system for a long time getting care without it coming to ACC's attention. And so there's going to be some variability in that. What will ACC pay for during that acute phase? Yeah, so they'll contribute to physio. What proportion of a physio cost do you think ACC will cover? It's about 35% they currently that they currently cover. I think they aim for 40. They might aim for 40 or 50. I can't remember. I heard the number recently, but they certainly don't aim to completely cover it. Yeah. What else might they cover other than physio? GP. Yeah. And what proportion of a GP fee will they cover? It's probably somewhere around about half. I mean, it is certainly cheaper to go with the GP if you've got ACC claim, but the key thing is they only contribute part to primary care. Okay, it's only once you get to a secondary care that ACC covers the full cost of care. They might also contribute to medications. Okay, excellent. So that's first one. Second one. So again, you probably don't need to read out the whom Maddie is, but just the scenario that is different about yours. So that, yeah.
Okay, scenario 2. Pain started while unusually walking down a number of stairs. Acute pain fails to settle. Signs and symptoms consistent with moderate OA. X-ray demonstrates moderate joint changes.
What did you decide?
Kind of similar to these guys. Like we thought the way in which the injury occurred it was like unusual, like they were doing something they wouldn't normally do and that caused the injury, so that might classify under the ACC funding. So we thought.
Do you know why?
Because it was, we kind of think like
accident.
No, it doesn't qualify as an accident.
But it's like
there's a specific definition within ACC for series of events. And so when there's an unusual series of events, so each step is an event, there wasn't a step they fell down, but that was a series of events that was out of normal. So that's why they could qualify. As opposed to if every day on their walk they did those stairs and one day their hip started hurting whilst doing those stairs, they wouldn't qualify.
Okay.
Yeah, so we thought like for that initial acute management of the pain, they'd get ACC funding through like physio and GP, but then if they need a more long-term management of the osteoarthritis, it'd have to be through public or private funding.
Yeah, so it ends up in the same place as number one, but unless you know about series of events, you might not give claims to everyone who deserves them.
Yeah.
But at the same point, people who have a gradual onset may not deserve it, may not qualify under the criteria. Okay, so who was scenario 3?
So gradual onset of pain over 3 months, timing consistent with when got a new dog and started walking a lot more. Signs and symptoms consistent with moderate OA. X-ray demonstrates moderate joint changes.
Right, what did you decide?
We thought this was largely self-funded. Though your series of events thing is curious with the new dog, but that's probably going to play long over time to account for that. So we thought self-funded with physio and GP appointments in this case.
Yeah, so they they wouldn't qualify for ACC. So they would have to fund all themselves or draw on health insurance had they had it, or rely on te whatu ora, but access to that care is quite difficult. Certainly in terms of acute care, getting into the DHB outpatients, not DHB, te whatu ora outpatients, pretty long lists and relatively restricted access to care. And then the proportion that may end up being getting joint replacement quite small. But what would have happened had Maddie also been walking their neighbour's dog and they were being paid by their neighbour to walk the dog?
They could have come under ACC.
Yes, and why is that?
Because it's like work-related accident.
Yes. And so ACC funds gradual onset if it is gradually onset at work. Does anyone know why that is?
Employee protection.
I beg your pardon?
Is it employee protection just to...
Yeah, so the whole reason we've got ACC was to meet our requirements under an international convention to look after people who are injured at work. And so that's why the whole system developed, and it was broadened to a whole range of other things as well. But it means that the supports are different for people who are injured at work than elsewhere. And so, if Maddie happened to be being paid for what they were doing, they would get coverage. Whereas if they were just walking their dog because actually improving your health and doing more physical activity is good for yourself as well as for the health system, they would not get support for that. Okay, so then going on to, I guess the only other thing I'd say with that, if Maddie did get paid for walking the dog, but also they did a lot other walking in their life, ACC might have a fight with them about, oh no, we think it's when you did your other walking rather than when you did your, so I've seen people with carpo metacarpal OA who have manual jobs where they do a lot of this, where ACC is trying to tell them, no, your problem's from pruning your hedges at home, not from spending 8 hours a day cutting fabric. And so often they will look for ways to contract out of that requirement. Okay, next one, are you guys number 4? You're number 4, oh, sorry.
Gradual onset pain over 3 months, history of multiple hip injuries starting with a labral tear playing football when he was 24 years old. Has had 2 other hip strains and 2 groin strains and a gluteal tendon tear that have been funded by ACC. Signs and symptoms are consistent with moderate osteoarthritis. X-ray demonstrates moderate joint changes.
Right. What did you decide?
For this, we decided that it probably wouldn't be funded by ACC anymore, so unless he has private health insurance, we have to go on the waiting list of the public system.
Mm-hmm. So why don't you think it'll be funded by ACC?
He's already been funded in the past, and it happened quite a number of years ago.
Yeah, so the key determination is whether or not those injuries increase the risk or the chance meaningfully of getting osteoarthritis. And for this scenario, the reason why it's written the way it is certainly muscle strains won't increase your risk of getting OA meaningfully, and so you wouldn't be able to argue with OA for that. Whereas labral tears are a more interesting space, in terms of there are a lot of people who have labral lesions who are getting labral repairs for the specific reason of preventing osteoarthritis in their joint. And there's a whole domain of orthopedics called hip protection surgeons, something about protecting the joint. But what's, I guess, an unanswered question with that is there's absolutely no evidence that people who have a labral tear have an increased risk of getting osteoarthritis, nor is there evidence that repairing a labral tear reduces someone's risk of getting osteoarthritis. Hip preservation surgeons, there you go, sorry. And so there are a lot of people receiving this intervention despite there being good evidence that it changes that outcome. But it means that somebody who is empowered, activated, resourced might be able to argue with ACC for funding for this because they could say it was related to that labral injury that ACC had previously accepted as being their problem. And so that might mean that there are some people with this who will end up getting ACC funding because they have the ability and resources to advocate for themselves, whereas there'll be others who will not. Okay, scenario 5, that'll be, yep.
So gradual onset of pain over 3 months. Maddie had a car accident as a 34-year-old that resulted in a acetabular fracture that was surgically stabilized. Signs and symptoms consistent with moderate OA. X-ray demonstrates moderate joint changes. So we thought ACC wouldn't really cover it here because the accident was like 30 years ago.
So you thought ACC, right?
Because it was 30 years ago and surgically stabilised and fixed, and they probably argue that age just kind of caused some of these symptoms rather than the accident itself.
They might try. Does anyone know what your risk of developing secondary OA is if you've had a joint surface fracture, particularly one that's required surgical fixation, compared to if you haven't?
Would it be higher?
Substantially higher. So to the point whereby ACC should fund this person's care because their osteoarthritis is more than likely a result of that joint disruption.
So they couldn't argue that it could be caused by something else because of that increased risk?
Yeah, exactly. Unless, I mean, if the person had a bilateral x-ray and the other side had exactly the same changes, they might try going down that route. But ACC do cover a reasonable number of people with osteoarthritis that's secondary, particularly, you know, if we go back to talking about fibrocartilage in joints in the 80s, it was really popular to whip out the whole meniscus for people who had a meniscal tear. And those people all developed osteoarthritis, and they all got ACC funded, well, they didn't all get, but they were all eligible for ACC funded joint replacement surgery, because we know if you take out a whole meniscus in a young person that their risk of OA is much higher, particularly if it's the lateral one. So this person would be eligible for ACC, but in order for them to be able to activate that, they would need to have their claim number that ACC accepted initially and the records that they would allow them to argue that. I don't think you could count on Te Whatu Ora to have the records for that, that surgery being done. So again, that means that if you have not stayed with your same medical practice over the period of your life, or you have had a more you know, a life that's involved more moving, more disruption, less ability to maintain and save records, you are going to be less likely to be able to tell ACC this is due to that thing that you accepted. And so it means there are portions of our community who are less likely to have access to all of that continuity, who therefore will be less likely to get care. Okay, final group over here.
Scenario 6, persistent hip pain for most of life, no disabling. Maddie had a SUFE when 13 that was misdiagnosed, delaying management and resulting in femoral head osteonecrosis. Signs and symptoms consistent with severe osteoarthritis. X-ray demonstrates severe joint changes. This was accepted by ACC as a treatment injury.
Okay, so first of all, what's a SUFE for everyone at home?
Slipped capital femoral epiphysis.
Yes, so slipped upper femoral epiphysis. Is what the U stands for, but you know, the capital will work just as well. Okay, so what is that?
The SUFE.
Yeah.
A slip disc. Pick it over actually. It's when the growth plate at the top of the thigh bone is fractured.
Yeah, and it slips, and so the head falls off the neck, for want of a better description. Okay. Who does that happen to?
Kids?
Yes, what sort of age?
Teenagers?
Yeah, early, so it's sort of 11 to 13. So it's at that time where they're getting heavier, but the growth plate has not yet fused. And so particularly if they are a heavier child, then there is more risk that they will overload that and it might slip. Does anyone know how you might identify a SUFE? What will it look like when it comes through your clinic door? Do you think it'll be any fun to stand on? No. So one, they will not enjoy weight bearing very much. Two, if the head slips on the neck, what's that going to do to the limb? It's going to be a short limb, and it will also likely be a bit internally rotated as well. So doesn't want to weight bear, limb looks short, internally rotated. Okay, so the first thing is don't miss a SUFE, because that results in the significant impact on the joint health that you're seeing there. So ACC accepted that as a treatment injury. I saw Maddie 6 months down the track, at which point they already had significant joint changes, and they all arose because it hadn't been diagnosed initially, and that's why ACC accepted it as a treatment injury. What did you think in terms of funding Maddie's care?
We believe that ACC would likely cover his condition lifelong because of the fact that it was a treatment injury, so the misdiagnosis and delayed management from the care that he received, I'm not sure where, resulted in the further complications of his condition.
Yes, so Maddie has a lifelong relationship with ACC with multiple interactions per year. So Maddie's receiving 4 pairs of new shoes each year that have the big I think it was about an 8 centimetre build up underneath that to moderate the reduction in leg length that arose out of that problem. They've got ongoing care and everything. So the reason why I highlight that is, so if we think ACC is like Rolls-Royce compared to those who don't qualify for it, hey? If you've got a treatment injury, it's like gold-plated Rolls-Royce in terms of how easy it is to access care and how comprehensive that is. But Maddie would always select not needing that, over that this had been managed more appropriately early on. So it's entirely appropriate that Maddie gets excellent care because Maddie's life has been disrupted by the system failing them. But what I'd want you to reflect on is that scenarios 1 to 5 have exactly the same condition. But the care we as a society give to these people is entirely different based upon some legal or health professional's interpretation of how their pain started. And those who are from some parts of our community who move around more, have less stable jobs, less stable lives, less understanding of how to phrase things when they're telling their health professional how their pain started, are less likely to get that care, and those people are more likely to be the ones who are less able to resource that care themselves. And so in your role as health professionals, it's worth keeping that in mind, particularly in terms of how you support people to advocate for themselves so that they can get what actually they deserve, which they might not understand themselves or have the resource to be able to advocate for. Does that make sense? What questions do you have about funding or ACC? Yes?
I know this is hard with video cameras on and everything, but what's your point of view on kind of blurring the lines about what happened with injury to get funding?
Yeah, I don't mind that with cameras on because I'm very open about what I do with that, and is that ACC, although it's got some problems, is a fundamentally excellent system, which is much better than the system I've worked in Australia, I've worked in the UK, I've worked in Switzerland, and it works much better in terms of the ability of everyone to get access to it. So I will stick to what I know of the legislation, and that if I think someone's injured themselves through an acute accident or through a series of events, then I am more than happy to do an ACC claim for that. If I don't think it has arisen in that way, I think it's more important to maintain the system through not cheating it than it is to try and make my own ethical judgment on you deserve care versus you don't, because I know that will be influenced by a whole lot of implicit biases that I don't understand and that I'm not aware of when I'm making those judgments, which means I'm more likely to give care to people I like, and that's not fair. So I think it's much more important that we advocate for the system to be fixed, which is people who have pain from osteoarthritis or other things deserve care from our health system, and if we give them care, they will contribute more to our community than they are able to when they are impaired by their OA, and it's much better we use our power to advocate for the system to do a better job than on a one-to-one basis of me trying to allocate care based upon whatever moral framework I think I might be using on that day. Does that make sense? Yeah. Right, so we want to then turn on to what are we going to do with that care. First of all, we want to be able to explain the diagnosis of osteoarthritis to the person because they won't know to do anything unless we give them some information. 2, we want to be able to explain what the management options available to them are and what the risks and benefits of those might be, including medication within that consideration. Okay, so we've done quite a lot of work over the last, must be 7 years now, working with people with osteoarthritis, health professionals, Arthritis New Zealand, trying to think what are the key things that are important to communicate about OA that enable people to engage in the care that the evidence says will help them. First is in terms of the pathophysiology, and this comes back to what I talked about at the start in terms of it being a dynamic process. Okay, osteoarthritis is not an end point. You don't suddenly go from having no OA one day to having osteoarthritis the next. It is a dynamic process affecting your joint. Now, the reason why it's important to focus on it being a process is processes are something that you can influence. So if it's like a amputation, one day you don't have it, the next day you have, there's nothing you can do to change that after that point in time. Versus it's a process, well then there are all sorts of things that might be able to influence your experience of that process or how that process is happening, and so that then opens opportunity for the person to have an active role in influencing their health. Second is that it involves many tissues. Most people focus just on the cartilage. They think of it just as a condition of cartilage loss. And so as a result of that, their understanding is you cannot reverse cartilage loss, and therefore there's nothing I can do. Versus if you understand that actually it has a big influence on the synovium of your joint, which becomes much more sensitive, well then you can understand that a lot of the pain that I might be feeling when I'm moving that joint isn't because of something going on in my cartilage, it's because I'm stimulating sensitized mechanosensors, and the best thing I could do with those is to move them more often, because that will desensitize them, and that pain doesn't mean I am damaging my joint. Secondly, if you understand how profound an impact it has on muscle function, most people have an understanding that muscles are organs that can be influenced by training. And so then most people can make the link, actually if I can therefore improve the function of my muscles, I can improve my osteoarthritis. And the evidence on that is very clear that if you improve muscle function, you improve pain and you improve disability. So it just starts to open out that lens of what we might do. If you understand that it influences the sensitivity of the nervous system, well then we can look at things that might influence that. If you understand that there are all sorts of factors outside of your knee that influence your pain, as we talked about in the pain session a few weeks ago, well then you can start to think about all of the other things that I might be doing that will enhance my health, that will also have the potential to be good for my pain. And so that understanding that pain is influenced by many factors outside the knee. Now, symptoms also typically fluctuate, which reinforces those symptoms cannot be due just to the structure of the joint, because your cartilage and your bone cannot fluctuate from day to day and week to week. During a flare, it can't suddenly look a lot worse and then look better again once that flare settles a week or two later. And so that understanding that my symptoms change, which nearly everyone with osteoarthritis will tell you, means there must be other things driving how it feels on any particular day or any particular moment that's not the joint surface. Thirdly, the joint noises are normal. Now put up your hand if you have a joint that clicks or grinds or makes a noise when you move it. Okay, so that's most people. No, keep your hands up. Okay, now keep your hand there if you attribute that noise to osteoarthritis. Right. See, it's interesting. If I had, nobody in this class is over 50, but if I'd asked the same question to a cohort over 50, probably 2/3 of you would have kept your hands up. We sort of forget that noises are a really normal part of joints. They happen across our whole lives, and they do not mean that you are wearing your joint out. But many people who are, as they get older and think they have arthritis, assume that noise means they are grinding away their joints. Does anyone remember the Arthritis New Zealand ads that were on a few years ago that had the red shards of glass inside the joint? What did that image look like to you?
That's a good question. I guess I'm associating arthritis with really intense, excruciating joint, kind of bone-on-bone pain.
Yeah, a scary image, hey? It was these red shards of glass, and it showed them grinding into the joint surface as the joint was moving. And we had Arthritis New Zealand up about this because they were using it in their advertising. They said, look, that's really great for driving membership, and we're a membership organisation, it's the only way we get money. But we were then able to show, it came out independently in our interviews with people with OA, how much that imagery was affecting their experience, because every time they heard those noises, they attributed it to them grinding their joint away further. And we saw it in the clinic often as well. So we did then manage to get them to change that advertising approach as a result of good data for that. So those noises are normal, do not represent damage. Thirdly, osteoarthritis does not always progress. So most people who have osteoarthritis assume it's just an inevitable decline from there to disability and pain and health loss. But this is the best data we have of the of the trajectory of OA. So this is from a group of 600, almost 600 people who were followed for 6 years. They were 64 age at average on recruitment, and they were just over half female. So what you can see from that is the single most common trajectory was that the pain was mild at the start and the pain was still mild 6 years later. Okay, so that's like 35% of the sample got no worse. Then we've got the second most common was that it was mild at the start and then it moved more towards moderate at the end. And so that's probably about a quarter of people. Third most common was, and there's a good 20%, just over probably. It was moderate at the start, moderate at the end. And the next most common was that it was moderate at the start, but it was mild at the end. So that improved. Now, often people do present for healthcare or joint studies at times of flare or when something is worse. And so that's not necessarily unexpected. And then there was a small group for whom it was severe at the start and it was still severe at the end. And that likely represents a failed health system in terms of we haven't given appropriate care to those people. But the thing I want you to focus on is that for 70% of these people, so that one, and that one, 6 years after they presented to primary care, their pain was either no worse or better than it was when they presented. And that's a completely different story. And if we can share that with people, then they have a much more hopeful understanding of how this might influence their health going forwards. Okay, next is that most people will never require a joint replacement. So if you look at the way that politicians interact with paying for elective surgery at elections, you'd assume that everyone with osteoarthritis needs a joint replacement and therefore we have to fund as many of them as we can. However, most people don't. And if we only focus on giving funding to that portion of the community with OA, there's a very large portion who never get anything from publicly funded care. But for whom the impacts will be affecting them and their ability to work and therefore their ability to pay tax and fund the health system. Final thing is that how we talk about it as health professionals is really important. So what we found, first of all, that people, how many people read this paper actually? I think I put it down as pre-reading, hey? Anyone? Okay, well you get a gold star. If I'd bought a chocolate bar, you'd get one. But that people really see osteoarthritis as this balancing act where they believe that when they use and load their joint, they wear it out, but they like to be active and do stuff, and so they have to try and balance out those two things. They see that they've got this sort of window of time before they are completely disabled, but they're worried that the more active they are, they will shrink that window of time by wearing the joint out. They have all sorts of activities that they enjoy doing and that add value to their life, but then they have things that the society tells them are safe to do for an osteoarthritic joint. And so there are all of these balances, and many of them were based upon poor data to start with, poor information. And a lot of that information comes from health professionals. So what I would encourage you to do is to be much more optimistic in the way you talk about this condition with people who have it, because that prognosis is much better than most people expect, and we know things that people can do to improve that prognosis in terms of pain and disability. Secondly, do remove the terms wear and tear and bone on bone from your vocabulary. So wear and tear how people interpret that is that when I use my joint, I wear it out. What do you think the evidence behind that statement is? Yeah, certainly, if that's what you think, it would make perfect sense not to use your joint. Yeah, but what's the evidence behind using your joint causes it to wear out? Poor, okay? People who don't use their joints are more likely to get osteoarthritis. Using a joint is fundamental to joint health. Joints need load, joints need movement, cartilage needs to be fed, all of those things. And so that stops people doing the most important thing they could be doing for that joint. If you get told you have bone on bone, what do you think that's going to do to you? Certainly you will attend more to that joint, and the more you attend to it, the more pain you will experience. Yeah? And you won't want to use it, hey? So I would suggest only use that term if you're looking to sell a joint replacement. At all other times, avoid it. Because actually, if it is bone on bone, well, you don't need to worry about protecting the joint anymore, hey? And actually, if you look in the anatomy museum for those bones that have really gone like that, you get this beautiful emery board on the end of the bones, and it gets better and stronger over time. And degeneration is just a horrible term, hey? And doesn't actually mean anything specific. If you get told you've got degeneration, how do you interpret that other than bad? It doesn't give us any information about what's happening in that joint or what we should do about it, but all it says is that you are failing over time, and it's only one way down from here. So really suggest that you remove all of those from your vocabulary. I mean, wear and tear, I believe, developed out of trying to remove the complicated word of osteoarthritis, which hard, inaccessible, and it was a time we thought there was no inflammation. It wasn't a good term. And so, oh yes, it's just an easy way to talk about it. But how people receive it when it's given to them, in addition to what we've talked about and changing their understanding how they can use their joint, it also feels really dismissive. Oh, it's just wear and tear. And so if you get dismissed, then you're less likely to want to present your health concern the next time you go in, even if its impact on you is escalating. And so it doesn't help people to understand what the problem is, doesn't help them to make the right care choices, and doesn't encourage them to share their burdens with you. And so it fails on all three counts. Okay, otherwise we want to get rid of those misconceptions that you can't do anything about this, and that exercise and impact are damaging or unsafe. So previously, people with knee OA would have been told that they shouldn't run. And often people are told that running is bad for joints, hey? However, now we've got good evidence that actually if you take a group of people with knee OA and you randomise them to you're allowed to run and you're not, 10 years down the track, the changes in terms of radiographic changes you see are no different between those groups, but one group is healthier and happier than the other. And it's not those who stopped doing their health enhancing activity of running. And impact is obviously vital for bone health, hey, in terms of osteoporosis. And so the more we can maintain people's ability to impact their bones over life, the healthier they will be. Okay, in terms of management. So that guideline I referred to earlier on has its recommendations based on strong recommendations where the benefits of something clearly outweigh the harms, conditional ones where it might do but it's not quite that clear, you might need to take some personal preference into account, and some strong recommendations against where the harms clearly outweigh the benefits. Okay, so the first one they have is weight management for people who are overweight or obese. Now, I would encourage you, and in the research we're doing, we do not focus on weight, because weight is a very hard thing to change, and very hard to predict how it might change for any individual when they engage in a weight loss attempt. And if you have spent most of your life being told that you are fat and then you get told your knee pain is because you're fat and your knee will only stop hurting if you stop being fat, that doesn't set you up with a lot of agency to be able to change that. And if we only give nutritional advice and care and information to people who we deem are large, then we are not giving it to a lot of other people who could benefit from it. So I would suggest you focus on healthy eating and drinking habits for all people, because that will improve all people's health, and we focus on gaining health rather than losing weight. And in terms of the evidence that supports that recommendation, so this is one of the 2 studies that informed that recommendation in the guideline, which shows, so this is their change in pain. So reductions in pain are up here, and this is their change in weight, and reductions in weight are here. And so what you can see is there is a clear dose-response relationship, and so if there's a dose-response relationship, that's good evidence, and therefore we can use that as a strong recommendation. But what you can also see is there's a whole lot of noise in there, hey, that dose-response relationship averages out. And so there are some people who lost a lot of weight, so this is like 15% and this is 20% of their weight, and their pain did not improve. There are some people who lost no weight and their pain improved quite a lot. And you wouldn't be able to predict where on that scatter plot an individual would end up when they came in and you decided they were fat enough to be told to lose weight. So I think we've got to be cautious about how we interpret this. This is a population indicator, and we know that as a population, the more people who have larger bodies, the more people we will have who have osteoarthritis. And so that's a population health approach that we should try and set us up with a less obesogenic environment. But it's not that useful. BMI is not a useful indicator of an individual's health, and engaging in dietary change is not a good indicator of whether or not someone will lose weight. And the final thing is that if you take individuals within this and you try and look at whether their change in pain can be correlated with their change in weight, it can't. And so there are probably lots of other indicators like changes in metabolic health or the physical activity that they engaged in as part of their weight loss that may well be driving that improvement in pain. So that's one of their recommendations that I don't think they'll change, because I know the people writing that guideline and are very wedded to fat people having to lose weight, but that I would encourage you to think about more broadly. The second one, and this won't change, is land-based exercise. But it doesn't currently, we've got no evidence to say that you're better to do muscle strengthening versus range of motion exercises versus aerobic exercise versus balance exercises versus Tai Chi and yoga, because they all have evidence of benefit, and there's no evidence that one is particularly better than the other. That might be because the way in which we measure those outcomes isn't very good, which is why Andy in his PhD is developing a better way to measure lower limb function. But what it means for us now is we can think about, well, what gives us the best collateral benefits for that person? And so if they're a person who has difficulty with their functional performance, getting upstairs, you might think, well, being stronger would be helpful for you. If they're a person who has osteoporosis, you might think, well, a strengthening program is good for strengthening bones, so that would be good to engage in. But if they're at risk of falling, you might think that a balance program is good, because obviously falling is your key risk of dying if you're over 65. Or if you've always done Tai Chi, well, you want to talk of that and encourage them to keep going. Conditional recommendations for other things that might be helpful, but the evidence isn't so strong, and so non-weight bearing exercise, the evidence is less strong than for weight bearing. Some people, you might need to start them doing that if they can't do weight bearing exercise without flaring, but you want to move them towards weight bearing exercise. And obviously we want patient-led goal setting to set the priorities for that. Okay, in terms of medications, there are no strong recommendations for drugs, because there are no medications for which the evidence of benefit clearly outweighs the risk of harms. Non-steroidals, there is evidence of mild reductions in pain with them, But in this population, the evidence of harms is not insignificant either. Older people get, the more likely they are to suffer a harm from a non-steroidal. So you would want to use it for as short a period as possible. And if you can get away with a topical that's much less harmful than a oral, and so particularly if you think about CMC, ACJ, even knee, where the joint structures are closer to the surface, it would make sense to try a topical one first. This guideline says duloxetine, as most of the ones in the world do. Does anyone know what duloxetine is?
If it's a T at the end, would that make it like an SSRI?
It's a SNRI, which isn't funded in New Zealand. Venlafaxine is probably our closest, but the venlafaxine hasn't been tested worldwide. We have tried nortriptyline, which is commonly used for pain, neuropathic pain or nerve-related pain in New Zealand, and that was found in a study in Christchurch not to be more effective than placebo. For osteoarthritis. And there was a trial they were doing in Auckland to see whether or not venlafaxine was not worse than duloxetine, but that got disrupted by COVID, and I don't think it'll be finished. So you might think about using a nerve agent, but only if you think this person has a nervous system mediated pain. And it has, now that question mark is mine. So they put corticosteroid injection may be considered for managing a flare, but more and more evidence has come out since that about the risk of a corticosteroid joint injection increasing the risk that you will need a joint replacement or further joint degradation, because cortisone is not good for collagen, and certainly with my OA knee I wouldn't let someone put cortisone inside there. And also, if you're thinking the person might get a joint replacement soon, you wouldn't want to give them cortisone because their risk of having an infection will go up. And then neutral recommendations for paracetamol, because there's not good evidence, but probably its harms are less than non-steroidals, although we're getting more emergent evidence that actually some of those same harms in terms of cardiovascular risk exist for paracetamol as well. Now, there's a strong recommendation against any form of opioid. Why is this? I beg your pardon?
Addiction?
No, addiction is probably not the key reason. A consideration, but not a key reason. So one, it's a really dumb idea for any long-term condition because the amount of it that you need over time goes up and your likelihood of getting side effects goes up, yep. But the key reason in this group, particularly if you think about there are more older people with OA than there are younger people. Drowsiness and falls. Okay, so falls is the key thing that's going to kill them. Why give them a drug that's more likely to do so that we already know is a dumb idea for their condition? And then you might consider orthopedic referral if all of the good care has been done effectively and for long enough and the person still has significant decline in joint function, their ability to sleep, their ability to walk. But you won't do arthroscopic interventions for knee OA because, like often we used to do, people with degenerative meniscal lesions used to have arthroscopic surgery to clean those up, and then they found that that causes more harm than good, and so they shouldn't be done anymore. But just to remember that up to 25% who have well-performed joint replacement surgery have persistent symptoms afterwards. And for knees, 15% of people have severe extreme post-surgical pain, and your likelihood of having severe post-surgical pain goes up if you have had mild pain before the surgery. So if you were less needing of the surgery, your likelihood of having bad outcome goes up. So we should reflect on whom we offer surgery to in private, because often those people wouldn't qualify in a public system. Okay. Sorry, I talked slightly longer there than I was anticipating, but what I want you to do in the final portion of the class is to practice in your own words explaining the diagnosis of OA to Maddie. When I say your own words, these are your words that don't include wear and tear, bone on bone or degeneration. And then swap roles and explain the management of OA or the management options that Maddie might be able to engage in. So we're going to restrict that to 4 minutes of direction. So we've got 1 minute for questions at the end. Okay, break.
What words you use in consultations to avoid using the words that we shouldn't say?
To avoid using the words?
We should not say like wear and tear, degeneration.
Right. Yeah, the same ones I shared with you at the start. Look, there's a process of joint change that affects the thickness of your cartilage, but it affects a whole range of tissues, and then go through and talk about those and the opportunities that those represent. So I guess the key thing is to move that discussion away from an impairment one, where I'm talking about what they've lost, to a solutions one, where I talk about the opportunities for the ways in which we can help them to gain more health. And that is a broad lens, not one that just focuses on the health of the cartilage, but that reinforces the healthiest thing you could do for your cartilage is to move your joint and use it, because that feeds the cartilage. And so that we can't ignore the cartilage, but we want them to know that using their joint feeds it rather than harms it. Now, why else was that hard?
I don't know, it's just hard to think of the right words.
Yes.
So,
yeah, and it is hard to come up with a different way of talking about something when you've got, you're only in the 4th year of your degree, but you've got all of the community myths that go with OA already that you will have picked up by osmosis across your lives. And so then changing that is hard, and it's hard to get your tongue around different ways of doing it, which is why it's so important to practice doing it with your peers, practice doing it with your pets, practice doing it with your whānau, practice doing it with patients when you get the opportunity in clinic. But we do have some support in terms of the models that we have developed for how to explain this to people are available for you to access. And so the Healthify page on osteoarthritis I have written most of. And our booklet is on there, but you can also get it from freefromkneepain.org, where we have a lot of the models that we have found to be most helpful for giving people a hopeful understanding of their osteoarthritis. And if you're really keen, on freefromkneepain.org, there is a clinician training page which has a collection of 6 modules that you could do to really understand more about culturally safe care for people with osteoarthritis, about how to explain it and interact with it in a way that empowers health gain, around how to think about physical activity, exercise in osteoarthritis, how to think about body size nutrition in osteoarthritis, how to think about medication review in osteoarthritis, and how to think about prescribing exercise. So you're more than welcome to access those. They should be available in our ongoing space if you want to come back to them later on. Kia ora, or vinaka vakalevu, to bring us back to Fijian Language Week, and thank you for your attention and engagement in this class. I love in Fijian culture when you get given something, you clap. And it's just a really nice way to acknowledge the reciprocity of that. So we've reached the end of the class, so I won't hold you all for extra questions, but if anyone's got pātai, then please come and ask them of me, because I love talking about osteoarthritis, as you can see. So go well and enjoy the rest of your module.